Good afternoon. My name is Jessica Gregg, and I will be speaking today about withdrawal management, which is also known as detox. And some very brief background. I'm the Chief Medical Officer at Fora Health, which is a substance use disorder treatment center in Portland, Oregon. We offer the full continuum of care, so that means withdrawal management, residential services, outpatient services. Prior to that, I worked at OHSU on the Impact Addiction Medicine Consult Service, and I developed a clinic called the Harbor Clinic, which offers same-day medication for patients with opioid use disorder. Prior to that, I was at Central City Concern in Portland and was the Senior Medical Director for Substance Use Disorder Services there and Medical Director for the Hooper Center and the Sobering Station before it closed. And the reason I tell you all of this is not to bore you with my employment history, but to give you a sense of the range of experiences that are informing the perspectives I want to share today. So when I was approached to speak here, the invitation for speaking carried a working title for the talk, which was Detox is the Gateway to Recovery. I changed that title to Detox, in quotations, isn't what you think it is. And that's really what I'm going to talk about today. I'm going to talk very briefly about what detox, I call it withdrawal management, is, what it is. I'm going to talk a lot about what it isn't. And then I'm going to bring it home with a little bit more about what it is and what we still need. So first, what is it? Withdrawal management is a brief medical intervention that allows individuals who have become physically dependent on drugs or alcohol to decrease or stop their use safely. In our setting, which is medically managed withdrawal management, that means 24-hour nursing 7 days a week. It means a doctor on site 6 days a week and on call at all hours every day. It means a lot of medications that keep our patients comfortable, but more important, keep them alive as they withdraw. It is a vitally important intervention for the health of drug and alcohol users, but it is limited. So I want to go through now, so that's what it is in brief. I want to go through now some of the things that withdrawal management is not, and I think that can be confusing for people. So first, contrary to the working title of this talk, I would argue that it is not the gateway to recovery. Last spring, just as the weather here was getting warmer, I admitted a couple older gentlemen almost right in a row. One was withdrawing from fentanyl and alcohol, and the other one, methamphetamine and alcohol. And I have a colleague, Dr. Ayo Enrique here, who, when she admits patients, she asks them regularly, what is your joy? What brings you happiness? What do you want to get back to after this? And I think it is such a beautiful practice. So I've been starting to do that myself. And so I asked both of these gentlemen, and again, it was so interesting. They came one right after the other. What gives you joy? What brings you happiness? What do you want to get back to? And they both said fishing. They both talked about, a pole in hand, a sunny day, the whole day in front of them on the water. And that is the gateway to recovery. The gateway is what they love and what they want to get back to. We can provide the medical support they need to get back to the water, but it is so important to understand that we are not the driver. We are not the reason that people are decreasing or stopping their use. And too often I get calls from other physicians or families saying, this loved one is drinking too much. This patient is using drugs. I just found out they need to get in to see you. And I have to say, do they want to? Is it the time? Is this the moment for them? Because we can't make people want to stop using, and we certainly can't remove the triggers for use or the trauma that maybe drives their drinking. So it has to be their time, and then we're right here. So we are not the gateway to recovery. We are a tool, hopefully, to help people get there when they're ready. Second, we aren't housing, and we're not even really a consistently available shelter bed. Again, we are critically important in helping someone to stop or decrease their use safely, which is often the only way for someone, for instance, to get into the vanishingly small supply of residential treatment beds or into sober living, because they have to be not using to get in. But for instance, we can't create housing where none exists. We can't decrease rents in a city that has seen rents rise by 40% in the last 5 years. And we are brief. So safe alcohol withdrawal takes about 5 days to get through that acute phase. Fentanyl, well, benzodiazepines about 4 days. Fentanyl about 3 to 4 days, and methamphetamine 2 to 3 days. So it is really short. And that is simply insufficient time for a case manager to pull, housing magic out of his or her hat. And if we extend that stay, so for instance, if we say, that's okay, this person who is withdrawing from alcohol, they really need 5 days of this medical intervention, but we're going to give them 10 because that's going to help us find potentially a residential bed or, maybe find some kind of housing. But if we do that, if we keep our patient 10 days, even though they need 5, that is 5 days that bed is occupied, that someone else keeps drinking or tries to cut down on their own and maybe has a seizure or is using fentanyl and doesn't get in, and maybe keeps smoking it or injecting it and maybe overdoses and maybe dies. So it's just not a calculus that we can make. So we are not housing, and we're not, unfortunately, really an answer to this horrible crisis of homelessness and addiction. We are a tool, but we are not an answer. Third, and honestly, this is a little bit off topic, but I really want to talk about it anyway. Withdrawal management is not a solution to concerns about the harms of new meth, which is also known as P2P meth, which some are really saying is the source of increasing crime and the problem of homelessness in cities. And it's not a solution to P2P meth or new meth, in part because methamphetamine withdrawal really doesn't require intensive medical interventions. Mostly people need to sleep and eat. And in part because this narrative around new methamphetamine really lacks robust evidence, despite being perpetuated by journalists and policymakers alike. And I'm going to keep going on this detour for just a little bit more. So for those of you who are unaware, in the late 90s to early 2000s, methamphetamine was largely produced and sold from little meth labs. So you could Google a recipe, and I've done it. You can find it in like 20 seconds to make methamphetamine. And it was made from pseudoephedrine, so Sudafed, in garages or RVs or just rooms in somebody's house. And it became a really big problem, not only because a lot of methamphetamine was distributed, but also because the meth labs were pretty dangerous. So there were explosions and people came into the hospital with really terrible burns. It was a big problem on multiple fronts. So in 2005, Congress passed the Combat Methamphetamine Epidemic Act. And what that did was put pseudoephedrine, so Sudafed, behind the counter at pharmacies. So you couldn't just come in and get it. And pharmacists had to track how much they were dispensing. In Oregon, we went a bit farther, and as you all probably know, you need a prescription to get pseudoephedrine from a pharmacy. And the act had a pretty significant effect. So from 2004 to 2011, lab incidents, so these explosions, decreased from an average of 24 a month to about 1 a month. And briefly, methamphetamine use decreased as well. But it was a brief decrease. So pretty soon after the act was passed, methamphetamine use started to increase again. And then it started to skyrocket, and it actually passed deaths from methamphetamine overdose, actually surpassed heroin overdose in 2015. And basically what happened is production of methamphetamine moved to Mexico to big industrial labs. The production was slightly different, so they didn't use, the precursor wasn't pseudoephedrine, it was phenyl 2-propanone, also known as P2P, which is also where P2P meth came from. So it was created in these big labs and then shipped up the I-5 corridor, where it is sold, was and is sold in California, Oregon, Washington, and the rest of the country cheaply, and it is now ubiquitous. So that is all true and verifiable. And that P2P meth is quite potent. So the DEA has looked at it, and it is more potent than, generally more potent than methamphetamine made from pseudoephedrine. But what is less true and not verifiable is this narrative, which is mostly driven by a journalist named Sam Quinones, about the effects of P2P meth on drug users themselves. In 2021, Quinones wrote a book called The Least of Us, in which he argued that P2P irrevocably changes drug users' brains. It makes them zombies. He says that they lose their memory and personality. They become, in his words, howling, hysterical, and starving. And they are these zombies are really the primary source, the primary driver of the surge in homelessness and crime in many big cities. He also says that because people lose their memory and personality and are zombies, they can't really meaningfully engage in treatment, and they must be generally mandated or incarcerated. And that narrative has caught fire. So there was a big article in the Atlantic. The book was featured. I heard Quinones speak on NPR, on the morning news shows. The article is taught at OHSU as part of an addiction medicine rotation in some of the residencies, and it is driving policy towards addiction and homelessness, including in Portland. And I can tell you anecdotally that narrative does not make sense. So nearly all of the drug users we admit to our withdrawal management program have some methamphetamine in their system, and many, many, many are using it daily. It is everywhere. It is ubiquitous. It is so cheap. But they are not zombies. They are not devoid of personality. They don't have scrambled brains. They're not incapable of seeking help. They show up intentionally in the morning. They stand in line and they ask for help. They just want help. So that's my anecdotal argument. There is also no scientific evidence for this assertion from Quinones. There is no evidence to date that P2P actually has a different effect in people's brains. And in fact, there's a researcher at the University of Colorado, Susan Calcaterra, who has just finished some research, which is not yet published, but is going to be published, where she looked at rates of psychiatric hospitalizations associated with drug use. And she showed that as rates of P2P use have increased, methamphetamine-associated psychiatric hospitalizations have not. So P2P use has for sure gone up. We know it. It's everywhere. It's the only methamphetamine really now. But psychiatric hospitalizations associated with that use have not significantly increased. Now, other psychiatric hospitalizations have. So the combination, people who use fentanyl plus methamphetamine, there is a significant increase in those psychiatric hospitalizations. And also, there's been a significant increase in hospitalizations, psychiatric hospitalizations, among people who are not using drugs at all. So there's just an increase in hospitalizations for mental illness across the board. And that's not, too surprising. According to the CDC data just released last August, rates of suicide are also continuing to go up. I mean, simply put, we are a nation in distress. And methamphetamine use may be a factor, one of the factors. And it's almost certainly a way that people are coping, but it is not the primary driver. And targeting a specific population and a specific drug as the source of our social ills is not just erroneous, it is really shameful. Okay, so withdrawal management is not the gateway to recovery. It is not housing. It is not an answer to the ubiquity of methamphetamine right now. And fourth and finally, it is not detox. So in alignment with the American Society of Addiction Medicine levels of care, what we do is called withdrawal management. And what we do specifically at Fora and also at Hooper is medically managed withdrawal management, which is called a 3.7 level of care. And the reason that matters, that it's withdrawal management and not detox, is that we know from as far back as, philosophers like Ludwig Wittgenstein to researchers like John Kelly at Harvard or Robert Ashford in Philadelphia, that how we use words really matters. It creates reality. And I'm zero interested, negative interested, not at all interested in policing anyone's language. And we know from the research that the language we are using around addiction affects the care that people get. And I think I particularly am interested in a study that John Kelly did, where he created two sets of narratives about a drug user. The narratives were exactly the same, except in one set, he described the person who used the drugs, as having a substance use disorder. In the other set, he described the person as a substance abuser. And then he presented these narratives to attendees at a conference, to experienced clinicians at a conference, at a professional conference. And he said to them, what should happen to this person? The people who got the narrative where the person was described as having a substance use disorder were much more likely to say, well, this person needs to go to treatment. The people who got the vignette that said this person is a substance abuser were much more likely to say, this person isn't ready for treatment, or this person needs to be punished. So how we talk about people who use drugs or who are addicted to drugs specifically, or alcohol, really it actually affects the treatment they get, even when we're just talking amongst ourselves. And similarly, if we refer to the service we provide as detox, it seems to me that we suggest both that our patients are toxic, and conversely, that the treatment that we provide is purifying or cleansing, and it will make everything brand new. But of course, it doesn't. We create the conditions so people are not physically dependent on drugs or alcohol. We do not remove the triggers that create cravings. We don't create housing. We don't increase access to primary care or to psychiatrists who accept Medicaid. We don't create girlfriends or boyfriends or mothers or fathers or children who are ready to forgive. And if we suggest that we are detoxifying or getting everything out of people's system and giving them a whole new reset, we are setting them up for failure and to be blamed for returning to use if they don't succeed. And this is particularly important in the era of fentanyl, which is both a terribly difficult withdrawal and has protracted post-acute phase. We work really, really hard to transition our patients who use opioids, and almost everybody right now, it's fentanyl, to transition them from fentanyl onto buprenorphine, which is also known as Suboxone or Subutex, which probably all of you know is a medication that decreases withdrawal, decreases cravings, decreases use, and decreases mortality risk from opioid use disorder by more than half. So we work really hard to get people on this medication. But even on the highest dose that we can provide, that we can prescribe, after we discharge people, and we discharge them with a full bottle of it, we really want people on this medication. We want them feeling better and 100% stable. But even with that full bottle, and even with it in their system, we see that if they go to our residential beds or if they go to community sober housing, that they're still feeling really lousy. And we hear again and again from our community partners, like, what are you doing? Like, you said this person, went through your withdrawal management. They're still anxious. They can't sleep at night. They're kind of like not comfortable in their skin. And it's hard for them to engage. It's really hard for them to engage and to just stay. But the issue is they don't need an inpatient medical setting. What we do is, besides sort of 24/7 nursing and the medications, it's dark. We want people to basically sleep and feel better. It's not an interesting place. It's not a place with distractions. It's a place to sleep, eat, get medications, get better. So once people are out of that acute phase, what they need is stabilization. They do maybe need a couple of weeks of something for sleep, maybe something for anxiety, but for a couple of weeks, but not 24/7 nursing in a bed in the dark. They need a garden, a basketball court, maybe acupuncture. They certainly need to be away from their dealers. They need nutrition. They need distraction. They need a place to land. But we have set up a system that expects detox and done. And that's simply not possible, particularly in the era of fentanyl. Okay, so just to reiterate again, we are not the gateway to recovery. We're not housing. We're not the answer to methamphetamine ubiquity. And we're not detox. But we are an intervention that matters for so many reasons. So as advertised, I want to start to wrap this up with a little bit more of what we are and then double down on what we still need. So, for those fishermen, for instance, withdrawal management provides the medical support they need to get back to the water. So they can't get back to what they love if they have a seizure when they're stopped drinking, or if they overdose, or if their aches and restlessness and nausea and just pain from fentanyl withdrawal is so severe they can't stop. We get them through that withdrawal alive and as comfortably as we can so they can take the next step. And similarly, we can be, and we are, a place for people who need to stop using to access sober housing or residential beds. We are also often the first step towards repairing a relationship. And we're also often just a place for people who want to pause. They're not committed to stopping. Maybe they don't even want to cut down, they're not sure. But they want to try a couple days without using, without drinking, maybe recalibrate, maybe think about doing things a little differently. And we're happy to be that place. And so importantly, we are a place that we start, and I know I've already talked about this, but I want to double down on it. We are a place where people with opioid use disorder can start on buprenorphine. We start them on the medications and we keep prescribing. We discharge them with that bottle and with Narcan. And we give them a phone appointment. We call them, they don't even have to know our phone number. We give them an appointment 3 to 4 days after discharge to see, can we keep prescribing that for you until we can get you into primary care that can prescribe, or, a treatment that prescribes, whatever it is. We want to just keep you on it and get you to the next step. We do not want you to die. And we know that when we do that, when we get them on the medicine and we discharge them with a full bottle and then we follow up pretty aggressively, we are saving lives, and that feels incredible. And finally, we're a place to begin to rebuild connection and trust. So when my children were little, and if they were sick or they had a bad dream or whatever little traumas in the middle of the night for little kids, I would often go into their rooms and say, I might get into bed with them. And I'd say, "Oh, sweetie, sweet potato, I'm here. I'm with you. It's going to be okay." And a few weeks ago, I admitted a gentleman to withdrawal management who was using alcohol and methamphetamine. And he had recently lost his children to his use and his drinking. And he was this big guy at one of those knit caps on his head. And he was sobbing over the loss of his children. And it was awful. It was heartbreaking. And I said, "Oh, sweetie, sweet potato, I am so sorry. I'm here." And he stopped crying and he said, "Did you just call me sweet potato?" Which really made me laugh, which made him laugh. And then we were both just sort of cracking up. And it was such a nice moment. And just a moment of connection. And that kind of connection really matters for so many reasons. And among those reasons, we know that people with substance use disorders are not treated well generally by our healthcare system. And they often then develop a really deep distrust in physicians, nurse practitioners, nurses, etc. And Carolyn King and colleagues at OHSU published a really interesting study in 2022 that showed that for patients with substance use disorders in the hospital, giving them compassionate, respectful care increased their trust in healthcare, not only while they were hospitalized, but in follow-up. Which means that they may seek care again. They may reach out if things get worse. They may begin to build back healthy lives with support. And conversely, if we do this wrong, if we are not respectful, if we are unkind, then we decrease trust. And we will likely see the downstream health and healthcare consequences from that. So yeah, we are also a place where we can treat people who are often mistreated with kindness, respect, and connection. So again, I've talked about what withdrawal management is, what it isn't. I talked a little bit more about what it is. And now I just want to end with reiterating this really important gap in care that is so vital for us to fill. There's been quite a bit of talk about the need for more withdrawal management services in Portland specifically and Oregon generally. And I think that's true. I think we do need more. But as important and potentially more importantly, we need a place for people, and especially people without housing, but all people really, to stabilize after discharge. And I don't mean just housing, I mean stabilization. So before we build more of the same, we need a place where people, after they leave here, can get their sleep under control, can feel like less not okay in their skin, can get nutrition, can get actually significant case management, can get connected to primary care, maybe to housing. Not intensive medical intervention, but care. And if we have that kind of post-discharge care, that will actually create capacity in our current withdrawal management or in any new withdrawal management that we build, because people won't be so uncomfortable in res or in their sober housing or even in their own homes that they bounce out and they come right back. They can keep moving forward to whatever it is they want and need and love. And if we build that kind of system, we can also do so much more. We can offer birth control. We can test and treat for hepatitis C and HIV. We can start PrEP for HIV and PEP. We can connect to primary care, as I said, all of that stuff. And if we can do those things, then we can get our fishermen to water, to their friends with boats, and to the whole sunny day in front of them. We are doing good, but we can do so much better.